I thought I'd share with you tonight a little bit of what I've been doing lately. And I sort of had my midlife crisis after practicing for a number of years in pediatric radiology. And my wife was happy that it wasn't the sports car. It was instead, going back into neuroradiology, which was always my first academic love. And I do enjoy a broad practice of diagnosis and intervention. But one of the areas that has captured my imagination and my interest in neuroradiology is the field of epilepsy. First of all, because I think epilepsy is such an important condition, and also because there's so much that we still need to learn about it. And then finally, epilepsy kind of combines my pediatric background with my neuro background, because so much in epilepsy has to do with development of the brain and growth and development. And we see the sequela of developmental insults, and we see the brain unfolding and how it responds to those. And we try to understand this condition of epilepsy. I have much to confess, but I have nothing to disclose to you. I have tried to stick to the Royal College type format in the objectives, which has of course made these incredibly long. I am not now, nor have ever been a member of the Communist Party. And anyway, what we're going to do is we're going to talk about the importance of identifying a focal lesion in a patient presenting with seizure and perhaps presenting with the onset of epilepsy. And I think this is a question that's relevant not just to neuroradiologists, because many of these people get their first imaging study in the community, and I have had colleagues from the community in general practice. I remember one in particular with a musculoskeletal background send in patients with focal cortical dysplasia, subtle lesions. And so when that happens, somebody's care is really advanced. So I think it's important we all think about focal lesions that might explain seizures. And we're going to look at some obvious things: vascular, traumatic, ischemic, and infectious, and inflammatory, to sort of get a sense of the spectrum of things that cause epilepsy. But of course, the developmental lesions are the most interesting in a way. We're going to describe some developmental issues that, when they go wrong, give rise to seizures. And we're going to see what we can squeeze out of standard neuroimaging studies to try to get to a diagnosis of a seizure-causing lesion. But we're going to recognize that our standard studies don't always take us there, and so we're going to foster an awareness of imaging innovations that may transform the practice of epilepsy imaging over the decades to come. And that's a process that we're all engaged in. I guess I'll have one disclaimer. I won't tell you that I've got the answer to these problems, but I'll tell you about how we're starting to tackle them and how we'd like to tackle them. So we'll do a little tour of things that I've seen lately. Welcome aboard. This is the tour operator's parking spot in Lunenburg, Nova Scotia, a stone's throw away from where I live now. Very idyllic little place. Epilepsy is common. That's the first thing that we should realize. The first reason why I think it's important. It is really common. This is not a rare disease that somebody somewhere at the far ends of the earth gets. This is something that a lot of people have. It has an incidence of about 40 to 70 per 100,000 per year. These are Canadian figures. And it has a prevalence of about 0.5% to 1% in the general population in Canada, and that is consistent across a number of studies that have looked at this. So 1 in 100 to 1 in 200, that means you know somebody who lives with epilepsy. Very, very likely you do. And in your day-to-day interaction with people over the last month, you probably met someone or interacted with someone who deals with epilepsy. The effects of epilepsy are pervasive. They're not just the seizures, which can take on a variety of forms, but the seizures really start to dominate the lives of people suffering from those sometimes. So first of all, there's the fear of increased mortality. People with epilepsy have a more than twice mortality compared to the average population from sudden unexplained death in epilepsy, or SUDEP, and from various traumas that can come about because of seizures. They have decreased health-related quality of life. They are less likely to complete secondary or post-secondary education, less likely to have full-time employment, lower income and social stigma that they have to deal with. With that, I don't want to say that all people with epilepsy have all of these problems. Many people manage very well, but they are a population of people that face challenges. There is an international league against epilepsy, as well as an international bureau for epilepsy, and these people get together periodically and they sit through long, long meetings, and they struggle to come up with definitions of things. And so they now define epilepsy as a disorder of the brain characterized by an enduring predisposition to generate seizures, and by the neurobiologic, cognitive, psychological, and social consequences of this condition. So it's a kind of a global, all-encompassing definition. What is interesting is that when I went to medical school, you had epilepsy if you had 2 unprovoked seizures. Nowadays, that's actually not necessary. 1 unprovoked seizure and an enduring predisposition to have more seizures is enough to make you a person with epilepsy, and a person who can be considered for epilepsy treatment, and that's usually pharmacological at the start. And so the question then is, well, what is an enduring predisposition for seizures, and how do you know somebody has an enduring predisposition for seizures? So that has to do with hard evidence that we can find, hard EEG abnormalities or imaging abnormalities. And that's why your imaging is actually crucial in turning a person from an unexplained, unprovoked seizure into a person with epilepsy, and launching them on a path of treatment and management. An epileptic seizure, transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. That sort of is familiar territory for everybody. That's how we tend to think of seizures. But again, as of 2010, gone is that whole breakdown of generalized tonic-clonic, generalized absence, partial complex, and partial simple seizures. More and more is there an attempt to link seizures to their specific etiology, channelopathies, if they can be identified, heritable factors or lesions. But we still have generalized epileptic seizures, which are conceptualized as originating at some point in the brain and then rapidly spreading bilaterally across distributed networks, and focal seizures that tend to stay within the networks limited to one hemisphere. And that begs the question, what are these mysterious networks? There's something that in the epilepsy world people talk about, epileptogenic networks, and we have this idea of webs of fibers in the brain that somehow allow seizures, uncontrollable impulses to spread all over the brain, but we don't actually know what those are, and what fiber tracts are more likely to conduct seizures, what fiber tracts would tend to not conduct them or contain them, why some people's seizures spread across the brain and why some people's don't. So I think there's fertile ground for a lot of research, and as our imaging capabilities start to include more and more molecular imaging and ultrastructural imaging such as diffusion tensor, we're going to explore those networks and understand the connectivity of the brain better, perhaps. The big question that a person who has just experienced a seizure has is, doctor, am I going to have another seizure? Is this going to happen to me again? That's what we would all like to be able to answer. And you can answer that question in terms of percentages, but that's a kind of an unsatisfying answer. Well, what are the things that, or what is first of all, the recurrence risk? Well, when you look at many studies, you find that the recurrence risk ranges widely from 23% to 71%. That's a useless range. The overall pooled estimate for that is about 50-50. That's also a kind of a useless number. You have a 50-50 chance of another seizure. Great, thank you. Now, if you have a certain constellation, like an idiopathic seizure, with a normal EEG, then your recurrence risk is about a quarter at 2 years. That's starting to be a little bit more of a precise figure. Why is there all this variability? Well, it would appear that the variability has a lot to do with the way this phenomenon is studied. Studies that are retrospective tend to be spiked by people with recurrent seizures, and so they tend to overestimate seizure recurrence rate. Studies that include new onset epilepsy as opposed to only patients with first seizures tend to be spiked by people with recurrent seizures and tend to overestimate seizure frequency. On the other hand, if you try to do a very clean study of first seizure patients, but you have a long interval between the index seizure and recruitment into the study, maybe that interval is driven by the wait list for MR imaging, which in Nova Scotia right now is about 20 years, then if you have another seizure in that interval, you're out of the study, and so you're left with a skewed proportion of people with first seizures. If the duration of your follow-up is very short, then you're going to obviously underestimate the seizure recurrence risk. Currently, 2 years is considered an appropriate interval. Now, is the underlying cause of epilepsy a major prognostic factor for recurrence? This is ancient data, but it still informs our thinking. Because if you have seizures because of a stroke or a vascular malformation, you have about a 50-50 chance. With a tumor or with a normal MRI, you're a little bit less than 50-50. And by the way, these are the people who are controlled but difficult to control. These are the people who are controlled with a single drug at reasonable doses. Head trauma, your outlook gets a little worse. But some of the most recalcitrant seizures occur in people who have cortical dysgenesis, who have malformations of cortical development. So the hunt is on for these things. Also, people with isolated hippocampal sclerosis have a bad prognosis. And finally, people who have dual pathology, meaning they have cortical dysgenesis somewhere, focal cortical dysplasia, say, and hippocampal sclerosis, have a really dismal prognosis in terms of their seizure control. Now, looking at treatment, surgical treatment of frontal lobe epilepsy, you become seizure-free or have only non-disabling seizures in a large percentage of cases if an epileptogenic lesion could be identified by imaging prior to surgery, and if the piece of brain you've taken out includes that epileptogenic focus. Whereas the chance of having an excellent outcome is only about 41% if there was no such imaging positive lesion that you know you took out with the resected brain. If you were based on semiology, on EEG and subdural recordings, and you took out the appropriate piece of brain, but it didn't happen to contain an imaging positive lesion. So the role of imaging in epilepsy. Etiology is the strongest predictor of prognosis. Lesional epilepsy has a very different implication as opposed to non-lesional epilepsy. First of all, lesional epilepsy is difficult to control pharmacologically. And second, if you can resect a demonstrable lesion, you are much more likely to do well than if you can't. And of course, we use imaging to help localize seizures along with history and with EEG, and we use it in surgical planning. It is said that if you have a convergence of imaging and EEG and history, then you may be able to do surgery without actually doing invasive monitoring like subdural electrodes, and that's surely desirable. On the other hand, if your scalp EEG recordings are not sufficiently informative, then having a demonstrable MRI abnormality helps guide the intelligent placement of subdural electrodes. And if you're going to go to the trouble of having such things put under your skull, you sure want them put in the right place. So, that's great, but what is the problem? The problem is that it is awfully hard sometimes to demonstrate these epileptogenic lesions. And there is always this kind of interaction between those of us who focus on the imaging and those of us who focus on the treatment of the patients, because the one group would really like to be shown the lesion and the other group is saying, well, I can't, it's not there. It's there somewhere, but it's not visible to me. This is a kind of a snooty paper, I have to say, because they talk about expert interpretation and non-expert interpretation. You know right away when you hear that. That's not very nice. And when they say non-expert, they mean neuroradiologists and general radiologists practicing outside of their epilepsy center. But what they're looking at is the initial report of a standard MRI in a person with seizures, and whether or not a focal lesion is identified, whether or not hippocampal sclerosis is identified. And then they look at the reinterpretation of the same study by their expert neuroradiologists who have had at least 3 years of practice at their epilepsy center. And not so surprisingly, their detection rate of focal lesions goes up. I think it goes up for a number of reasons. First of all, these are expert neuroradiologists, but also I think they've been given a selected group of patients who have made it to that center because of their intractable seizures. And they have just been informed that this patient has intractable seizures. Here's an MRI. You must look again. And by the way, this is how the seizures play out. They start with a little finger and so on and so forth, right? And before you know it, you can almost map the location of this problem in your head. And so not surprisingly, the experts do better. But they don't do really, really awesomely well either with the images they're given. Their performance improves significantly when they get to have images that are really optimized for the detection of seizures. And that, I think, is the useful point to take away from this paper as opposed to this part. This part here. If you can sharpen your lens, then you may be able to detect very subtle things. If you approach it, of course, with attitude. So here they give an example, and especially in this lighting, this is not the most convincing example, but as you can obviously see, there's a very subtle focal cortical dysplasia in this paramedian gyrus here, which is much more obviously seen with the appropriate slice angulation, thickness, and matrix. They found that dedicated MRI, dedicated seizure MRI, showed focal lesions in 85% of patients with non-lesional standard MRI. That is a kind of a gauntlet thrown down. That means we really should do better than we do. Or we should make sure that we're doing the best we can with having the kinds of imaging that should show this pathology. So I think the biggest problem is this. Too many gyri, too little time. Scrolling through these things, how easy is it to go slice by slice by slice, especially if you make the slices really thin, such that you now have 150 slices in the coronal plane, so on and so forth. But we can only try. So the first thing we need to do is we need to really optimize our acquisition. The next thing we need to do is we need to sharpen our eyes and our minds, and we need to optimize our interpretation. And finally, there may be opportunities for additional post-processing techniques and using everything that signal processing and computer engineering can give us to supplement our radiological judgment. In Halifax, we work with the very best of equipment, and we are proud of that. This is our routine brain protocol. We put through, as you do, a lot of patients, and so we've really trimmed our protocols to the bare bones. Our routine brain is sagittal T1, axial T2, axial flare, and axial diffusion. As a matter of fact, when we were really strapped for resources, when I was in pediatrics, we didn't have our MRI at the Children's Hospital yet, and we got to go over twice a week for 2 hours to scan, 6 to 8 children who were waiting for an MR, with sedation and all that. We used to have one of my colleagues with their famous SAG T1, AX T2, and punt protocol. But here we have 4 sequences. Now this would not do as an epilepsy protocol, right? You need more. So to make this an epilepsy protocol, what we did was we added coronal views that wouldn't quite cover from the very front to the very back, but that would certainly give us decent views of the temporal lobes and confirmatory coronal plane in other parts of the brain. T2 proton density, which was in favor back then, and inversion recovery. But we soon modified that. First of all, we thought, well, in the routine brain, diffusion is of kind of limited use. We do it on everyone because we do it routinely and we get used to the artifacts, but we can actually do something more with this. What if we started to collect information on diffusion tensor imaging just along the way? We might not now interpret it for that particular patient, but we might think ahead that this is going to become an important way of looking at epileptogenic networks. Let's start gathering the information. Let's start getting used to this as our diffusion-weighted sequence, and then having it available. We improved the coronal T2 view of the hippocampi, which of course always should be angled to the temporal lobes, but which can be further improved by increasing the numbers of excitations, by optimizing our matrix and bandwidth, and I'll show you an example of that. We cover the whole brain with FLAIR for lesion detection, and we cover the whole brain with a 3D volume acquisition for detailed anatomy. So now, as you can very easily appreciate, our coronal T2s have become much sharper and much better. And we use the flares for lesion detection, as in this case, bilateral hippocampal sclerosis, and our T1s, our volume acquisitions for detailed anatomy. This also gives us the opportunity, should we want to do some fancy morphometry, we have a volume data set for that. The next concern that we had was that we are not getting very detailed volume T2-weighted information or FLAIR information, and we've been fortunate now to have Cube, which is a volume acquisition, much like the 3D FSPGR for T1, and it allows us to get multiplanar T2 and FLAIR information, as well as everything else that I've shown you. And these Cube sequences are really very impressive in the sagittal view, which is the acquisition that we usually do, not because the sagittal view is particularly good for seizures, but because the head is narrowest in that direction, and so this very time-costly sequence can be played out most efficiently that way, and then we can reformat it in other planes. When we do, we get pretty decent coronal and axial images. But actually, I'm in the process of revisiting my thinking about this, because pretty decent is actually not good enough. I think it should be really excellent, and so I may revert to some more primary coronal and axial acquisitions as we go along. The general principles of epilepsy imaging then are whole brain coverage, 3 imaging planes, or at least targeted coverage in 1 to 2 planes, and volume acquisitions with reformats in the others. We should aim for the highest possible spatial resolution and signal-to-noise ratio. We should keep our slice thickness at or below 3 millimeters, because we are studying the gray-white matter interface, and our gap should be 0, because, again, we don't want to be confusing blurring from an en face or oblique lesion with real blurring of the gray-white junction. We should have all the standard MR flavors. Magnetization transfer may be a very useful sequence that we have not yet implemented, but Gilbert Vezina has in Washington, and finds more cortical dysplasias with this. GRE, or susceptibility weighted imaging, if you're interested in cavernous malformations, and GAD if you're interested in the DVAs that point to them. And there are a variety of planes in which you can slice things. These are some of the planes that favor detection of lesions in frontal, parietal, temporal, occipital lobes in the perisylvian region. So, what sort of lesions are detectable by imaging? Vascular, destructive tumors, tumor-like lesions, malformations of the brain, and malformations of cortical development. And we need to pay attention to the hippocampi in particular. So, of our vascular lesions, this is sort of not very sophisticated stuff. Arteriovenous malformations. Some people in this room may remember this very case. Easily detected by CT and confirmed by MR. Not so easily detected by CT, this cavernous malformation, but very obviously detected by MR with T2 or gradient echo sequences, as in this case. And when cavernous malformations are in the cortex, they're irritating to the cortex and they're very epileptogenic lesions. And yet resection here has an excellent chance of rendering this person seizure-free, as it did indeed in this particular case. Other things, destructive lesions, stroke, trauma, infection, and this inflammatory lesion, Rasmussen encephalitis, can all cause seizures. Here's an obvious old stroke with an island of cortex suspended in a sea of encephalomalacia. And this, in fact, has been associated with seizures, and these are the strokes that are most likely to cause seizures, those little islands of suspended, preserved cortex. We have destructive lesions like old trauma, classic location for contusions. Sometimes you have to look a little harder and more carefully and scan the whole examination to find the areas of contusion or gliosis from an old trauma to get to the bottom of the seizure disorder. And sometimes, on the other hand, it's not very difficult. This is a baby with toxoplasmosis infection. And sometimes time has the answer, although here in 2001, in February, it's kind of noticeable that there's a difference in the volume between the two hemispheres. That volume difference becomes greater with time, and the right hemisphere, which is the hemisphere that is undergoing continuous or very frequent seizure activity, is gradually experiencing atrophy, in this case of Rasmussen encephalitis. Tumors and tumor-like lesions. Again, there's a cluster of things that typically are associated with otherwise healthy young people with a history of chronic epilepsy, often temporal lobe epilepsy, low-grade astrocytomas, oligodendrogliomas, gangliogliomas and cytomas, and DNETs that are beginning to be kind of in the borderland between tumors and congenital malformations. So again, we don't need terribly sophisticated imaging to detect mass effect in the temporal lobe here, as evidenced by the displacement of the MCA of a glioma that only minimally changes the density of the CT, or the rather more obvious calcification of an oligodendroglioma here. But we do MR, of course, to further characterize these tumors. And then some tumors have a classic association with seizures and a classic appearance, as in this ganglioglioma with the enhancing nodule and the cystic component. And then this is an absolute classic, which is that wedge-shaped, cortically based lesion extending, pointing into the subcortical region with a kind of a bubbly, frothy appearance on the inside. This is a DNET, a dysembryoplastic neuroepithelial tumor. And its orientation here kind of hints at its developmental origin. This is on the borderlands with focal cortical dysplasia. And here's another one showing the more gyriform appearance and attesting to the fact that these are very chronic, very indolent lesions. They scallop the cortical surface. Oh, and here's a classic enantiomer, a hamartoma of the tuber cinereum. So, what's interesting is to think about the development. If you think back, think way back into your embryonic days. Okay. You were beginning to compartmentalize your neural tubes. in the 4th week, and then you were beginning to develop a telencephalon in the 5th week, and these protohemispheres would start to grow and bulge over your brain, and by the 8th week you were beginning to develop a laminated cortex. You were having neurons travel out from the subependymal germinal matrix zones into the cortex to lay down a cortex, and you were making various commissural fibers to connect the hemispheres. So when things go wrong that early, you can get some very profound abnormalities like holoprosencephaly, or kind of the opposite, agenesis of the corpus callosum. This is the most profoundly malformed brain I've seen yet. We have the usual falx here. We have another falx here. So this is kind of a split falx syndrome. I'm inventing that on the spot, which gives rise to this funny skewed appearance. These are obvious malformations. They're not a diagnostic challenge. The malformations of cortical development are the ones that are diagnostic challenges. So here's that process whereby you start with neuron precursors in the germinal matrix. You lay down radial glia that are going to serve as guides out to the forming cortex. And then these cells have to migrate, and they have to decide on the proper layer where to settle down and start making connections and go to business. There's a classification of the various malformations of cortical development pioneered by Barkovich. And the first of these are the disorders of proliferation and apoptosis. As you know, we have more cell proliferation than we need initially, and some of these die back. And if you have not enough proliferation or too much dying back, you get microcephaly, a perfectly formed little brain, just too small. And you get heterotopias if migration is abnormal. You may get little nests and clusters of cells that kind of deposit themselves on a ventricular surface or somewhere in the mantle on the way to the cortex. And these are kind of fun to hunt for. What you have to do as you're scrolling through the images is you have to keep outlining in your mind the surface of the ventricles, and then the mantle, and then the subcortical white matter. And eventually you start finding these little things that parallel gray matter on all sequences. Now, the thing that we don't know is, even though these things are associated with seizures and with epilepsy, do they cause seizures? And if so, how do they cause seizures? Or are these the tip of the iceberg? Are they the visible part of a developmental derangement that somehow leads to seizures? Here is another case with what I like to think of as the double caudate head sign here, where one of these is a nodular heterotopia. And here's a case that illustrates not just a whole string of nodular heterotopias along the surface of the occipital horn, but also the fact that there is a developmental field abnormality, if you will, in this entire lobe. So the nodular heterotopias, again, are just in a way that a tip of the iceberg. They are the visible sign of a process gone wrong, because the white matter here is much thinner. The mantle is much attenuated. And then the gray matter at the surface is also thrown into abnormal convolutions and has a kind of a cobbly, stony appearance. So any one of these findings can be a clue to the presence of others in that same developmental field. And I think they're a hint that there is more here to this disease than meets the eye. Cortical organization means that these cells all have to lie down in the right layer and that they have to make the right connections with each other. And in conditions like polymicrogyria, it seems that the cells run and they don't know when to stop, and then they start clustering near the surface. These can be difficult to detect, especially when a screen is backlit. But what you're looking for is very fine microconvolution all along the gyral surface. And then you realize that this is not a simple six-layered cortex, but a disorganized, cobbly cortex. This young man presented with a quote-unquote stroke, but in fact had a seizure, and it was related to this polymicrogyria on the surface of his frontal lobe. And sometimes those polymicrogyrias are involved with abnormal clefting and abnormal fissure formation of the brain. This one does not quite get to the ventricular surface like a classical schizencephaly. And as a matter of fact, there are a number of neurons here that sort of didn't make the departure and stayed at the gate here. And if you have that condition bilaterally in the sylvian fissures, you have the perisylvian syndrome, which involves not just difficult to treat epilepsy, but language and speech abnormalities and swallowing abnormalities. And we come to some interesting lesions, those of neuronal migration that leave band heterotopia along the developing mantle. The first and most obvious of these is lissencephaly. This is actually a term neonate, an ultrasound that shows a very, very smooth brain. This might be appropriate at 20 weeks, but not appropriate at term. And unfortunately, this was done at a time when there wasn't an MRI at our children's hospital, so I don't have an MRI. But what it will show is actually a very broad zone of gray matter with a tiny sliver of white matter and another little dusting of gray matter at the surface. And that's what these lissencephalies really look like when you scan them. There is a form frust of this condition, which is diffuse subcortical band heterotopia. And it's interesting because in radiology we do the windshield wiper approach, and we're always looking for things that are asymmetrically abnormal. And that works very well in the nervous system, except when you have a symmetrical abnormality. And this person was imaged at two epilepsy centers with multiple MRIs before finally the diagnosis was made. And there is a band of gray matter that just follows underneath the cortex diffusely. And so this is the form frust of what I showed you before. This is a woman with an X-linked condition, a double Cortin gene problem, who has this subtle band heterotopia. We were very pleased with ourselves and published this so that people would know to look for it. And just as I was all proud of myself, I managed to miss a case of the same thing, which has a very subtle band running just along in parallel with the ventricles here. So these are very, very difficult to detect, I like to think, but we need to look for them. Chance favors the prepared mind, and half the battle in looking for these epileptogenic lesions is to expect them and to expect their appearance and to look for them. So then we have a number of disorders that relate to proliferation of cells in focal regions of the brain. And these are very interesting. These are the focal cortical dysplasias and hemimegalencephalies. When you first look at this study, you might think that you have somebody who has been placed in the magnet askew, or if placed askew, that the images have not been properly corrected for a nice anatomical projection. But if you look carefully, it really seems that one lateral ventricle is a little bigger, and that everything is a little bigger on one side. And if you get coronal images, it becomes obvious that indeed this hemisphere is bigger, the gray-white differentiation throughout it is poorer, and you have some increased signal in the white matter that attests to the dysplasia of this entire hemisphere with hemimegalencephaly. And this can be really very, very subtle. It can look like somebody who's just not quite straight in the magnet, and so multiple planes are always essential to make the diagnosis. And in fact, you may find that sometimes hemimegalencephaly, as in this case, doesn't actually involve the whole hemisphere, but tends to relatively spare frontal regions and involve parietal and occipital regions a bit more. and yet this is the condition. Along the same lines, you can get disorganization at a focal point in the cortex. And you can leave a trail of balloon cells here that give you high signal, the so-called transmantle sign. Having this is very helpful because it helps you find the focal cortical dysplasia. These are extremely epileptogenic lesions, and if you find it and if you can resect this, you can do a lot of good for this person. Of course, tuberous sclerosis is just, in a sense, a case with multiple of these things all over the cortex. But there are focal cortical dysplasias without balloon cells, and they do not tend to leave this transmantle sign, so they're very, very difficult to identify. Here, for example, the very subtle blurring of the gray-white junction was not initially appreciated. People have proposed that using 3 Tesla MRI is helpful here because of the increased signal to noise. And certainly, if you compare 1.5 to 3T, you can see that some of these lesions become more obvious, become sharper. Though sometimes when you make that comparison between 1.5 and 3T, and you look at this, you say, well, with the wisdom of hindsight, though, I think it is there, and the scan is showing it. Again, chance favors the prepared mind. So in this case, we tend to sometimes send difficult patients to Montreal for 3 Tesla imaging, and so then they come with lesions identified, and in retrospect, of course, we do find them. So that's a stern reminder to us to use that technique of always scanning along the cortex and scanning until we find something and correlating with the clinical information. Because once you know what region of the brain to focus on, you're much more likely to make good use of your time in finding it. One of the ways to make good use of your time is to look at the bottom of sulci. More than 80%, almost 90% of focal cortical dysplasias live at the bottom of a sulcus. And look for the deepest, longest sulcus, and you're more likely to find the lesion. Look for a very subtle transmantle sign if you can see it. And here's something we've been experimenting with, which is to put surface coils on the brain in the area that we expect to find the lesion. And then we put arrows on the lesion to make it that much clearer. But we're not the only ones, because when we send these people to Montreal for their 3 Tesla scan, they also put arrows on the lesion and so have great success in identifying the same lesion here. So, according to Knake's group, the best thing you can do is to use 3 Tesla MRI and surface coils until 7 Tesla MRI comes along. And then there are people who are doing wonderful work with looking very specifically at tracing out the cortex with automated image processing methods and assessing then the thickness of the cortex everywhere, the sharpness of the gray-white junction everywhere, and the signal on both sides of this trace everywhere. That's just more than the human brain can take. But that's kind of what you want to do for these cases. So I look forward to the marriage of automated image analysis and radiological analysis to try to maximize lesion detection. We looked at this old paper before, and I just want to point out again that if you have a temporal lobe epilepsy with hippocampal sclerosis, and especially if you have dual pathology, it is very difficult to control you pharmacologically. And there's pioneering work that came out of this center, London, showing that these people do remarkably better when they are treated aggressively with temporal lobe resection. And so, in fact, the number needed to treat to get rid of disabling seizures is 2, which is fantastic. And even if you're looking at any seizures, the number needed to treat to get rid of those is 3, and that's still a fantastic outcome. And so being able to confirm an abnormal hippocampus, and being able to take that out with confidence is a great, great benefit. So what do we do in order to assess the hippocampus? Well, we optimize our imaging once again, and I might as well not try to trace these bits of anatomy for you on this screen. Trust me that we can see them. And what we're looking for is gray-white differentiation, normal lamination, normal shape of the hippocampus, normal corrugation of the pes hippocampi, and normal signal all throughout. And then if we don't see those, we are unhappy, as in this case where you have a small hyperintense hippocampus in very obvious mesial temporal sclerosis. And sometimes you have flattening of the hippocampal head. It lacks the normal corrugations in the pes hippocampi. And that is an early sign of volume loss in the hippocampus. Sometimes, again, the windshield wiper approach fails you, and you can glance at something like this and figure that it must be normal. And so it is important to take advantage of all your sequences, including your FLAIR. Just one caution on FLAIR imaging: if you adjust your contrast just right, you can make almost anyone have hippocampal sclerosis, because FLAIR will show those areas bright even on normal people if you're not careful. So you need to also look at the volume. Here's somebody with a very vertical collateral sulcus and a kind of a rounded hippocampal body. That's been termed hippocampal malrotation. Really, it's a failure of the hippocampus to assume its final sort of oval configuration. And there is fierce debate in the literature over whether this is an epileptogenic lesion or an incidental normal finding. And some people say they never see it in normals, and other people say they see it in anywhere from a quarter to half of normals. So the jury is out on that. What we are beginning to do is formal hippocampal morphometry, because this has been well shown by Bernasconi's group in Montreal that if you measure the hippocampus, you can often find robust differences side to side and between normal people and people with temporal lobe epilepsy. And this may one day inform our decisions. But I have to tell you, it takes a day to do the processing. So at the moment, this is not really a clinically viable option. But I think it will be one day. We also do spectroscopy, and of course, as people's hippocampi become more and more damaged with repeated seizures, eventually the NAA peak comes down. This is also apparently correlated with pharmacoresistance. So we're very interested in taking people now when they first present and predicting pharmacoresistance. But you have to take these data and you have to actually quantify them and normalize them and use something like LC model rather than what comes straight off your clinical software in order to get reproducible values. So again, this is very time intensive and something that needs to be streamlined. Diffusion Tensor likewise. So these methods are not easy to incorporate into current clinical practice, and they've not been extensively validated for clinical practice. That's what needs to happen next. And I think we need to look at prospective cohorts of patients presenting with first seizure, and we need to study them longitudinally to understand if we can map some of the biochemical and structural changes that occur and use that information to predict seizure recurrence, to predict drug response, and also to confirm the presence of the epileptogenic zone and maybe to understand how epilepsy works. So those are some of the challenges that we've put to ourselves and to the epilepsy imaging community. And we use the Halifax First Seizure Clinic to try to do that, because we have a wonderful situation where we are the only referral center for the whole province. And Maritimers tend not to move away. They do occasionally go out west to work, but then they always come back. And so we have a captive population, and we will study these people longitudinally with standardized means and multimodal assessment. We are finding now that if we look carefully at their imaging, we see a variety of lesions. But the interesting thing is that there is a kind of complementarity between neuroimaging lesions and EEG findings. We expected to see lesions correlate with EEG findings. And yet we are finding lesions in some people with normal EEG, and we are finding abnormal EEG in people with lesions. And so it may be that, again, the lesion is the tip of the iceberg. There is a more widespread network problem that we need to understand better, and we need to continue to use multimodality assessment to understand these patients. We are prospectively recruiting, and we are taking this one step further to specifically study pharmacoresistance and study prediction of next seizure using random forest statistical modeling of multiple factors, including neuroimaging and clinical factors. And this is work in progress. We're interested in looking not just at hippocampal structure and volume and spectroscopy and DTI, but also diffusion kurtosis, which may be a more sensitive way of looking at cellular derangements or tissue derangements. And we're very excited about what the next 5 to 10 years will bring. This is funded by the Nova Scotia Health Research Foundation and these Dalhousie sources. My colleagues are Bant Pullman-Eden, who's an epileptologist, Karen and Susan, who are nurse practitioners in the epilepsy realm, Matt Blanchard, who's a student working with us, Mohammed Abdulel, our statistician, Kirk Feindel from physics, and Candace Crocker, our research associate. And without all of these people, that kind of work would not be possible. Anyway, I leave with this picture, which I pass whenever I go walking in Point Pleasant Park. This is a memorial that was left to Walter Hose, the founder of the Canadian Navy. And his friends wanted to recognize his achievements. And they said, in adversity, neither politics, lack of money, nor ridicule could beat the determination and courage of this officer. So it's sort of an unfortunate compliment. But without reservations and without any awkwardness, I really want to say thank you very much for coming today, for hearing what we're doing in Halifax about epilepsy. It's been a great pleasure, and I welcome your questions.